Right, I think we'll make a start. Thumbs up that you can still see my screen. All good, excellent, great. Lovely, well, hello everyone. Thank you for joining the East of England branch AphA launch event. Thank you for your time and nice to see everyone. My name is Alex Ryan, so I'm Head of Business Informatics at the East Suffolk and North Essex Foundation Trust, but also the branch lead for AphA East of England branch. Really looking forward to this event. We've got a really good group of people who've joined up, and we've got some really good presentations today as well. Really pleased to introduce them. Just a bit of kind of meeting hygiene. The meeting, just so everyone knows, the meeting is recorded, and obviously if you could try and stay on mute until you're asking a question, that would be very much appreciated. Please do feel free to introduce yourself in the chat. Just stick in your name and your job role, and that would be really helpful. So in terms of the agenda for today, my screen will move on. There we go. So I'm going to kick us off with a little bit of a introduction. So I'm conscious that there will be quite a few people on the call who maybe don't know a huge amount about AphA, plus probably not members, but there's also some content I think is quite new and relevant to existing members as well. So it may at times seem a bit like a sales pitch. So apologies if it does, but I want to give everyone a bit of an intro. We're going to get everyone involved today as well. So we've got some really good speakers, but today is also about hearing from all of you around how you think this group is going to add value and what content you would like this group to cover. So keen to get your views, and we'll have the opportunity to do that at a few breakout rooms. We've then got Heather Humphreys from the Health Economics Unit, who's going to give a presentation on health management techniques. And then Hugo Herrera, who's Head of Advanced Analytics at ESNEFT, is going to talk us through the kind of ESNEFT analytical journey around how we've gone about developing our health inequalities analysis as well. And that's, whilst that will be a presentation, keen to get everyone's feedback on how we could improve that work as well. And there'll be a little bit at the end, again, to get everyone's views around what our next steps should be. So you've all done lots of Teams and Zoom calls over the last 18 months, and you'll all know that no presentation is complete without a Menti. So can I ask that you, on your desktop or on your mobile phone, just nip into menti.com and then enter the code that you can see. And there's just a couple of questions that I just want to ask everyone to just understand who's on the call, where you've come from, and what you know a bit about AphA. So I'll let everyone give everyone a minute to get on it. But if you could, the code is still at the top. If you could just stick in what organisation you represent, so we can sort of see who we've got today and how well we've sort of covered the East of England area. Already starting to get quite a nice diversity of organisations, so it's really good to see representation from OHID as well, which is really cool. ICS colleagues and SNE, that's great. Local authority colleagues, fantastic. CCGs. The Walton Centre travelled a long way down to the East of England today. Great stuff. Nice to see lots of different organisations represented, and that's fundamentally what this is about. And then this is a question that's come straight out of the social research textbook. Are you a AphA member? Yes. No, but I'm going to be. So interesting to see that there's actually quite a close balance. I wasn't necessarily expecting that, so that's really interesting. Okay, about 50-50. So that's really good, and it's good to know that there's plenty of people who could still join up, but great to see that we've got really good representation in the group as members as well. So moving on. Okay, so just to cover a bit of background around AphA, particularly for the 10 of you who are not yet members. So what is the purpose of AphA? Why does it exist? Well, AphA aims to champion analysis across health and care, and is trying to make sure that analysts are recognised as the experts that they are, and are able to add huge value across the health and care sector. And is principally trying to do that through the provision of professional frameworks and support networks as well. So what it's trying to do is effectively drive up quality and applicability of analytics to fundamentally try and evidence that we are affecting decision making across a modern, digitally driven health and care system. But what AphA is also trying to do is raise awareness amongst the organisations that we work for of the importance of the role of membership and professional accreditation, and how that in turn can strengthen the healthcare sector by enabling us to deliver more robust analysis in the future. So that's kind of what AphA really exists for. In terms of its kind of strategic aims, just to run through this really quickly, it's about trying to help us develop analytical capacity and capability across our systems, and make sure that analysis is recognised as a profession with progressive defined career pathways. It's trying to develop thriving analytical communities, both at national and local levels, so that we can advance skills, share knowledge, implement good practice, and then, as I said before, try and affect decision making. It wants to give us the best experience that we can get as members, and part of that is about linking in with other organisations, research, academic community, and try to forge some collaborative relationships. And it's also trying to help us develop robust analytical methods, and in particular by making sure we keep quality of care and experience part of everything that we do as analysts. As I said before, it's also making sure that we try and promote the value of analytics and the independent and provide independent thought leadership on that through lobbying, influencing, and challenging key decisions. So what's in it for you, I guess, if you become AphA members? Well, one of the key ones is professional accreditation. I'm going to go into a little bit more detail on that in a second, but huge amounts of information on the website. Events and workshops are also really key. So AphA hosts a lot of different events, including this one, as well as the annual conference. The regional meetings, they're not just restricted to your own region as well, just to be clear. So because you're from the East of England region does not mean that you cannot go and attend an event in, say, the Southwest, because there's some speakers that were of interest to you. And ultimately, we want to try and develop networks across the nation as a whole. There's a series of webinars, workshops that you can get priority booking at, and the monthly magazine. So the monthly magazine is a really excellent read. Lots of really good articles from some of the kind of leading kind of thought leaders in our profession, if you like. Really good articles by other analysts who have done some really good work that they're sharing, and quite often sharing actually how to reproduce that analysis as well. So the magazine in itself is really excellent. Website with analytical resources, and that's where the presentations from today will go. And obviously forging communities and networks of like-minded analysts, such as what we can achieve through this group. And ultimately, through access to all of this, it's about helping people develop their careers. And there's awards, an annual awards ceremony as well. So that's the kind of AphA offer in summary. So on the professional accreditation, so a really important part of the AphA vision is to have professionally registered analysts. So all members have the opportunity to become professionally registered with the Federation of Informatics Professionals. I'm not going to go into huge amounts of details of this, but there's 5 different levels, and the associate practitioner one is just opened up to all members, and that's the kind of first foot on the ladder, if you like, to start your kind of career development across the and up through the other levels. Really, so why would you do professional registration? Well, for me, it's an opportunity to demonstrate that you've got the right level of knowledge, skills, and competencies. But those have actually been validated through an external review process. So it's kind of endorsement of your professional skills. And it helps you evidence that you have the right level of abilities. And I think it's also a really good way to show your commitment to your own career and your own professional development. And it's quite straight. I'm not going to go into details. It's quite a straightforward application process. You just need to create a portfolio of evidence and reflective practice, and that will be, as I said before, externally validated. So for me, I think this is quite timely and really value adding. There's a huge amount in the literature right now around the kind of role of healthcare analysts, and a lot of these kind of articles on here will be familiar to people. So look, going back 18 months, a lot of this sort of started around the kind of Ben Goldacre review, which was looking at how analysts can play a more significant role across the NHS in particular. But more recently, there's been really interesting publications by the strategy unit on how we can advance analytical capability. And a lot of this is based on the observation that within the NHS, there's around 10,000 analysts, but a lot of those roles are advertised as admin or clerical, and that doesn't really reflect the technical nature of our role and the fact that these skills take many years of education and experience to develop, as well as the fact that actually a lot of our role is more of a clinical or scientific nature to it. So ultimately, if the health and care sector of the future wants to continue to get really high quality analysis, organizations that we work for need to really recognize the expertise and skills that analysts offer and reward that. And that means recognition of analytical skills and analytical leadership skills, as well as more defined career pathways. I think it also means inspiring analysts. And I think that the recent comment by NHS England CEO Amanda Pritchard at NHSP conference is really welcomed when she said, a good analyst can save more lives than a good anaesthetist. It might not be very inspiring if you're an anaesthetist, but it's particularly inspiring if you're an analyst who, particularly if you've been through the challenges of the last 18 months that we all have. So I think that for me, it's a really good recognition of the role that analysts play in the sort of strategic impact that we have across delivery. AphA's got a really key role to play around the sort of professionalisation of the analytical workforce, if you like. And AphA was commissioned by NHSX to start developing a health and care competency framework for all healthcare analysts. That is now in draft form. That's what the front cover looks like. And that is now available to all AphA members. And it's been tested by several organisations, including ESNEFT in the East of England region. And that's principally been developed on the Digital Data and Technology Profession Capability Framework in the in central government, and that sets out the key behaviours and skills that we could sort of expect of analysts at different levels through the professional registration framework. So for me, really positive development, really useful, and absolutely something that we're going to want to talk about in future group. So this is when my sales pitch goes up to a whole new level. And like all good analytical leaders, I've taken someone else's analysis and presented it. So membership, it starts from £37 a year, not at. It's £47 a year if you're band 7 or above. But at £37, it's £3.8 a month, and that is less than an Americano and a croissant. And with significant price inflation over the last couple of years, I would say that is even better value for money than it was before. So yeah, good value for money. And just to be clear, we accept tea drinkers and non-croissant eaters in the East of England region as well. So just to, I'm gonna stop talking. So yeah, join up if you haven't already, and for those of you who have already signed up, fantastic. Please, contribute to this group going forward. Right, I'll stop talking. We're now going to go out into breakout groups. So the way this is going to, so we've got 15 minutes, and the way this is going to work is there's going to be 4 breakout rooms. Each one will have a facilitator. I've just put the breakout room details in the chat, and they're based on your surname. So for instance, if your surname begins with A to C, you're group 1, D to G, group 2, so on. You can just have a look at the details in the chat. What we're going to do is we've got 15 minutes for that, and feel free to take a 5-minute comfort break afterwards. Just try to be back in the main room by 3:35. And your facilitator is going to ask just make sure Heather's in, because she's one of the facilitators. we're going to ask you a Christmas-themed kind of intro question, and then we're going to ask you about your expectations for this group and how we sure that it adds value. And the context for this is there's lots of analytical groups kicking around, all have their own different kind of focus. We just want to make sure that this adds unique value. So keen to get your thoughts on how to do that. So can I ask that you now join your breakout room and come off the main chat, and we'll see you back here at about 3:35. Okay. Hello again, everyone. So I think we've got most people back in the call. Thanks for your flexibility with timings. I feel like it's going to be one of those sessions. So we'll start feeding back from the groups. I think there's enough people back in the room now. So I'm just going to go down the groups in order and just ask the facilitators to just give a bit of a summary. So I'll kick off with group one. I won't summarize the worst Christmas present, but there were some horror shows in there. But in terms of the kind of how do we want to use this group? What do we want from it? I think there's a kind of a few key words that I'll just focus on. I mean, the collaboration and networking. So subtle differences. So I think a recognition that the group can be used for networking across different organizations, that kind of represent the system as a whole, and there's an opportunity for networking. Collaboration. So again, looking both at identifying where everyone's trying to solve the same problem and seeing where we can work together to solve the same problem once rather than doing it all separately, and also looking at where the same problem exists but across the system as well, and seeing whether or not you can particularly use the opportunity for people who work in public health and people who work in acute to come together, because although there are kind of public health groups and there's acute groups, there's maybe not quite so many that brings everyone together. Robin Andrews said something really nice, which is there's power in communication, which, you know, is effectively just there's power in getting together and talking, which I think is great. We need to not lose sight of our USP, which is, you know, principally around professionalization. And there's also something about these groups not being too formal. We shouldn't necessarily expect, you know, people to come to present who wants to, you know, produce a really polished, professional looking presentation every time. There's equally as much value in bringing work that may still be in development, presenting that early for thoughts and contributions. Doing that is tricky, and we'd probably want to bring some examples and try and generate some momentum. So lots of really good content, and thank you to everyone who contributed to that. I will now pass across to Hugo for group 2 summary.
Thanks, Alex. I will keep it short. I think the two questions about expectations and how this group will add value summarized in cross collaboration. So I think people really will expect the branch to help us to collaborate across different organizations within our region. But we were also discussing that we add value by being able to collaborate with other networks that are already there. So, you know, opening opportunities for sharing, you know, platform or sharing the forums with other people, so that they can share the work they're doing or share techniques or solve problems. So we were also talking about trying to collaborate with other regions and, you know, for very specific topics, and how can we use the East of England branch as a vehicle to do that. So people that is part of the of AphA is England can potentially, through is the England branch, connect with people across the country that are doing very specific things, working on mental health or working on public health or very specific issues where they might find that in our region, well, there is only a couple of analysts doing that kind of job. But when you look wider, you can find more colleagues that you can share your expertise with. So I think overall is yeah, it is collaboration across different organizations in the region, but also across the different networks that are both nationally and regionally already established, and are bringing together analysts from different organizations.
Lovely, thanks very much, Hugo. Right, I think Jared, you stepped in group 3.
Yep. Hello. So we've kind of touched on some of the things that you've already kind of covered. So around the sharing of knowledge, how we can collaborate and work together. One of the things that kind of hasn't been brought up yet that we kind of touched on was the benefit of the networking aspect of this. So how we, you then create that network, you've got points of contact within all the various other organizations. That there's also a benefit that if we can share large pieces of projects or work that we're currently going to be doing or are in the pipeline, it may very well be that someone within the same sort of geography is looking to do a very similar thing. So actually we can pair up and work together on one project as opposed to individually doing two. So the sort of networking aspect is going to be very beneficial because it just allows that to kind of progress and work forwards. The fact as well that we are looking at the same sort of geography, so the east of England, it does mean, so where we're looking at the likes of public health management, population health management, sorry. If we do then start going, actually, well, we can start bringing up some of these ideas and other areas of thinking of it as well. That just cements it even further that, it's fantastic to be able to do this as one project across a larger area because we can get more benefit out of it. We also spoke about the accreditation is very helpful in terms of structuring and being able to kind of take things forwards. Not only because it then gives us the ability to understand and recognise what we think we can be capable of based on where we are, but on the flip side, if we're looking at doing any form of recruitment, it kind of gives us that base to, what skills are we looking for, where are we, what are we after, because we already know who should be sitting in that kind of role in the first place. So that's kind of the bits that we were talking about.
That's really helpful and some really interesting additional insights in there, Jared. And thank you for stepping in. Yeah, James.
Brilliant. So the beauty of being fourth is that I can usually just say, basically, we discussed everything that you've already discussed, but there's a couple of things that I will focus on. So in terms of expectation for group and events, so again, yeah, of course, we spoke about networks, collaboration, learning from each other, what is applicable from one kind of, area, i.e. social care into healthcare, into public health. But what was interesting was that, first of all, the expectation for groups and events is around actually supporting individuals to become accredited, looking at the different levels of accreditation and how we can develop brand new users in the system to get them accredited, as well as supporting the needs of those people that have been here like me for a very long time. Secondly, expectation from group and events is not to go away today without knowing how we then kind of join and the next steps. So that's kind of huge for new people into finding out about AphA. So those kind of joining instructions and where can we find out more. Looking into the unique element of the unique value around AphA. I mean, yeah, first of all, accreditation, absolutely huge. Exactly as Jared was saying, the idea of how do we use AphA as an advocate for the recognition, the use of that accreditation. So looking at that into applications for jobs, getting that into policies for organisations, but also hoping that the groundswell of AphA users in organisations almost naturally takes that into those kind of policies of recruitment. So that you can sit there with your AphA badge alongside potentially your GSS analytical badge and say, you don't need to ask me. People have already approved me. And then yeah, and a huge part about the fact of really kind of utilizing AphA and that driving analytics as a profession, really kind of reinforcing and being that voice for analysts, where rather than kind of number crunchers, but really kind of echoing that fact about what you can save with good analysis, where good analysis can take you in terms of decision making. Again, really being that kind of, and I think that's the uniqueness of it, is being that champion across the system. We're all kind of, you know, champions within our own networks. We're all here kind of saying, yay, public health and analysts within local authorities. But rarely do we have it at a kind of system level that champions that. I think that's basically, oh, and yeah, an opportunity to basically bleed techniques between domains. So again, within our networks, we often talk to public health people about public health. We talk to population health people about population health. We talk to performance people about performance. But actually, and we talk to social care analysts about social care analysis. Actually, the more we can bleed and learn both mistakes and also, you know, successes between those functions, the more we kind of raise the potential innovation within those functions as well. So I'm more than happy to write out the rest. We've got two sides, but you know, I think that's where we are with number 4. Thank you very much.
Yeah, fantastic. Thank you, Raj. Loads of fantastic comments. Yeah, really appreciate it. Thank you very much. Right, I'll pass now across to Heather Humphreys, who's going to give a presentation. So Heather, can you check you're okay to jump on and share your screen? Do we have Heather?
So Heather was a bit intermittent when we were in our breakout group because she's in a big concrete building. So her internet access was a bit patchy.
Oh dear, we may have lost Heather. What?
The list does say that she's still in here, but
Oh, here we go.
Can you see me and hear me?
We can see and hear you, yeah.
Okay, cool. I think I have sent Val my slides. Have you gotten them yet? So this device is working for like talking and hearing you guys, but it won't do PowerPoint. So I'm trying to like patch it. Is that working? Ooh, this might work.
Got you. Yeah, we've got your slides.
You guys can see that?
Yeah.
Ah, cool. Okay. So hi everyone. I'm Heather Humphreys, and I am currently doing a master's at LSE, which is why I'm in this. You can see I'm in this like giant concrete building they've just built, surrounded by construction. And I have to wear a mask because I'm in public, like inside though. I work at the Health Economics Unit, which is a sister organization to the Strategy Unit with MLCSU, which is in the Midlands. And we basically do about a third like kind of commercial projects, and the rest of our work is either NHS or nonprofits. We do economic evaluations, analytics, that kind of stuff. My backgrounds are in economics and public health, and I've had a particular interest in population health projects, so that's what I've been doing at HEU for the last few years. So today I'm going to talk to you about population health management, and I think a good place to first start is, what is that? I ran a series of workshops in the spring where I talked to people from all over the country, experts who were implementing it, and said, what is this? And the only thing that they all said was different definitions. So for me, it kind of matters less the exact technical wording, and it's more population health is this idea, this approach that we're going to take to solving health problems. And it's rooted in a lot of economic theory and statistics, epidemiology mixed kind of with econometrics. And then population health management is where you've taken those theoretical kind of academic disciplines and you've put them together in a systematic toolkit that you can use in a methodological way to kind of say, this is the evidence for why we're making these decisions in designing these methods of care so that we can allocate our resources effectively from a population health perspective. So population health is kind of an approach, an idea, and PHM, where you're going to hear it everywhere, think of it more of as a technique or a set of tools that you're going to use to do a particular type of analytics. So the type of analytics that you'll do with PHM specifically is that you're going to bring in data from different sources. So it might be from councils, local authority, social care, adult care. Maybe you have some ambulance, so like LAS data, housing associations, all different sectors of police, for example. You bring all these different sectors together and you might have different insights. So when you're doing things like planning for a PCN or for these different levels, you can have GP, sorry, this class just got out. So you can bring all these different sectors of like the government space together to work on issues that cross different sectors. So obesity doesn't just happen in your GP office. Obesity happens in your schools, in your local, whether or not you have access to parks. Are those parks safe to play in? These types of, are you living in a food desert? These types of things come into play. So PHM is going to specifically do a couple of things. You're going to look at a defined geographical area, and you're going to have a defined budget. And those are really important because a key thing with PHM is that you're trying to do cost effectiveness from a population perspective. So you need to have a defined budget for a defined number of people, defined geographical location. And then building on that, it's going to focus on identifying opportunities where we can get the most gains from a health perspective, as opposed to what we did maybe, in the past, where we tried to optimize our costs through maybe drugs or different types of procedures. How are we going to minimize the cost by looking at who is spending the most? Now we're going to look at getting cost reductions or increasing value by targeting the numbers. We're going to play the number game of, if we can get a lot of people, how are we going to affect large numbers of people? And then in aggregate, that will create large gains that we can get. And the overall point is to achieve the triple aim, reduce health inequalities, and in the long term, improve the health of the population. So this is kind of where population health management sits in my head. You're going to be drawing from a lot of different disciplines. And so no one that you meet doing this is going to be an expert in all of these things. So I'm a health economist. My colleague Bruno is an econometrician. We'll collaborate on projects. So he'll advise me on some of the statistical methods I might want to use, what types of modeling I'm going to do for like causal inference stuff. And I'm going to bring in the economic theory and my background in public health to say, like, this is how it's going to fit in a national context. All of these different like academic theory is really important to incorporate in PHM projects, because a lot of times preventative health or PHM type programs are criticized because they haven't kind of consulted with enough range of views before starting a project to adapt it to a local situation. So the key thing here is that you're not going to know everything when you're doing the analytics, but running it by a bunch of people that have specialties in these different areas is really important to having it be successful. So PHM draws on some specific aspects of health economics that are particularly key. One is this idea of scarcity. So we have a finite number of resources that we need to allocate across a population. So we have a defined budget for that defined geographical population. So how are we going to split that between our GPs, our A&Es, and our surgical care, or our, commissioning diabetes apps for people's phones that we provide through primary care. Figuring out where our priorities are is key as a first step of PHM, and figuring out what those stakeholders are interested in, where are your gaps, what's going on, kind of getting a lay of the land of what you're looking at. And then thinking about your opportunity costs all along the way. So at each stage, thinking about, if you do this, if you come out here and give this presentation right now, then you're not over there studying or catching up with my husband to find out how the dogs are doing, that this is the first time I've left them in a while. So whatever you've given up to do that activity is your opportunity cost. And then each additional effort that you spend on something is your marginal costs and benefits. So for example, the vaccination programs are incredibly important, right? We want to vaccinate everybody for COVID. But is it worth vaccinating the last person in the UK? So at what point do we need to say, okay, cool, we vaccinated the number that we think we're going to be able to vaccinate for the amount of money and effort that we have, the substantial amount of additional resource we're going to need to spend to get to that last person, is that really worth it? And that type of thinking is going to play in PHM. Because PHM is looking at your value for money. So measuring the outputs that you're getting for the associated expenditure. And value for money is highlighting where those gains are and is going to help you set priorities. So it's important to consider what your priorities are from a maybe national strategic level, right? So one of them is that we want to reduce inequalities. That's a priority. So we know that from the start, but that's also something that's going to come up again and again as we develop our programs. And really quick on inequalities. So there's equality and then there's inequity. And usually when we say inequalities, what we mean is inequity. Equity is people having access to the same resource based on their need. So in this picture, for example, if we give everyone the same bike, it's only useful for one person in reality, like, because the guy's hunched over, he's going to develop some problems. The kid can't bike, it's too big. Giving people what they need to achieve a similar health outcome. And that kind of ties into understanding the wider determinants of health. So in order to understand who's going to need what bike, we have to think about what people, sorry, my slides aren't moving. We have to think about what factors are actually affecting health. So these are two ways of thinking about it. There are multiple models that I think there's like 3 or 4 now that are considered widely to be pretty robust. And they vary in estimate from about 11% to 20-ish, 25% of your medical care actually impacts your health. The rest of what makes you healthy, the rest of what's giving you your health status is coming from these other things. So these social circumstances, your individual behaviors, your physical environment. Do you live in an area where you have to walk through very polluted streets to get to class, and there aren't really playgrounds or any green space nearby? So opportunities for exercise are limited and you're exposed to a lot of pollution in the air. That might have an effect on children's health, right? So when we think about the fact that so much of our health is coming from these other areas, PHM is going to say, hey, other sectors of society are responsible for those. So feeling safe contributes to anxiety. The police are involved in making us feel safe. So we might want to bring them in and have discussions with them about the data that they're collecting, overlay it with our A&E violence rates. For example, with like the Cardiff model is an example of that. It's an interesting case study to go look at if you haven't seen it. Bringing in police data and A&E data to reduce spontaneous violent crime. So violent crime that is unplanned. So getting in a bar fight and breaking a bottle and stabbing somebody with a broken bottle, right? That's unplanned violence. You attacked a stranger because you got a little drunk in a bar and got in a fight. Those types of things have huge costs to the health system and can be identified using this way of thinking by pulling in these other sectors, talking to local authority and figuring out where maybe potentially vulnerable people are living alone in their housing. And so that's how bringing that thinking in is where the toolkit comes into play. So the Phm Toolkit has 3 main categories of tools. You have segmentation, risk stratification, and impactability. So segmentation is going to be a whole population level view. Risk stratification is going to happen on an individual level, and impactability is going to be subpopulation level. And that's going to come in really important when you're designing your analytic methods of what you're going to choose, how you're going to choose it, and then apply it. And then what kind of data do you have? It's very difficult to do some types of risk stratification if you have like large aggregated data sets where you don't have access to a more individual breakdown, for example. And how valuable are the results of that? And then impactability is this third tool that is slightly less understood, but a lot of research is being done in it. We've actually done a lot of research on it this year and are publishing it around, specifically Andy, the director of the Health Economics Unit, is very, very, very interested in impactability. And it's this idea of how likely is our intervention going to be and having an impact at this subpopulation we've identified to try to have a positive impact on. So the first one, so segmentation. Why are we going to segment? We have, for years and years, we've had, summary statistics or means or medians. It seems to have been doing a pretty good job, right? But its usefulness is going to decrease as your complexity increases. And as we're adding in these other sectors like police and local authority and et cetera, our data sets are becoming bigger and more complex. And that's, a challenge because it's bigger, more complex data. We're kind of overwhelmed with almost too much data. But it's also a good thing because when a lot of these theories, so going back to that academic discipline stuff, a lot of this was developed decades ago. But we didn't have the integrated data sets with the length of history behind them to make them useful. We weren't able to segment in close to real time. Like before, if you had data that was like only 1 or 2 years old, that was great, right? Electronic health records and integrated data lakes and cross-sector pulling together of data has enabled us to do subpopulation level analysis that we couldn't do before. And that's really hard and challenging, but it's also really cool for us as analysts because we have access to stuff that the world is huge and has lots of opportunity, which is awesome. So the key idea around segmentation is you're going to take your whole population and you're going to split it into groups. And you want the best data that you can for this, but the main point is that you want each grouping to be as distinct as possible. And ideally, you want people to only fit into one group. So if you're going to have a long-term condition group, and you're going to have a cancer group, and you're going to have a mental health group, is anxiety and depression a long-term condition, or is it a mental health problem? These types of things are important to think about when you're creating your segments. And I suggest thinking about what you want to actually do with it. Are you trying to inform what types of conditions you're looking at? Or are you trying to think about services? Are we going to give more money to mental health or to cancer services or to this other type of service? So perhaps splitting it into different groups might be more effective for your end goal. And there are lots of software packages that you can use to do segmentation. You can also use free tools like R. There's lots of R training, specifically if you're interested in more training on R. There's a really active NHS R community that you can sign up to for free, and they have lots of events and information and training and stuff. But yeah, so there's lots of opportunity for doing this. There are multiple methods of segmentation. There isn't one right way. and there isn't like one fits all approach. So it takes a bit of thinking about the problem that you're trying to solve, and then, you know, all of that background stuff, the wider determinants, the scarcity problems. What do we want to focus? How are we going to assign our priorities in determining what type of segmentation we're going to use? So this is one example of a 3x3 grid, and in it you see age against health status. And then from the simple visual, you can kind of see a pretty decent picture of your population in a more broken down way than just your average spend per person is this. Your total spend of the CCG is that. And this can kind of help you allocate resources. Another example here is where you still have age along the y-axis, but you have more groupings. You have cancer split out from learning disabilities. And we might want to allocate resources or target interventions to those different groups in different ways, because cancer patients theoretically have significantly different needs than learning disability patients or people. And so determining the number of groups, the overall number of groups that you want, and how detailed you need those groups to be, and then creating hierarchies for assigning people to these different categories. That's all part of your segmentation tool. The next tool in the toolkit is risk stratification. So this is saying at an individual level, where are you in the population? What is the likelihood of a particular event happening? What's the likelihood that you're going to end up in A&E? What's the likelihood that you're going to have another admission this year? What's the likelihood you're going to have a heart attack, an asthmatic event that ends up in hospital, a stroke, etc.? And there is some, there's a lot of discussion and conversation. An article that the strategy unit recently published is particularly interesting on this, and that is whether or not it's actually going to help us with using resources. Because is knowing that that heart attack or stroke going to happen, how useful is that? Can we even do anything about that? And is dedicating this resource to determining that risk worth the time? And how do we figure out if it is? And how do we decide what factors, what variables, what outcomes are worth actually creating these risk stratification models? Because some of them are quite complex and take time to develop. So risk strat models tend to kind of fall in three categories. You have a clinical perspective where a clinician uses their knowledge of a patient. You have threshold modeling where you say, everybody who meets the threshold, you know, if you meet this threshold, then we consider you at risk for XYZ, and it triggers this pathway of events. You get a letter in the mail, we want you to come in for screening, etc. Predictive modeling is kind of more a bit where we come in as analysts. So this is multiple regression, this is decision trees, AI, machine learning. This is where we can kind of create specific tailored models to help us with risk stratification. And it's important to note that you might not need to make the model. So there are several, I wouldn't say many, but there are models that are available off the shelf in the UK that have been, you know, a lot of time and effort has been spent developing these. The Health Economics Unit is currently developing two for COPD, and we're going to compare them, one using machine learning and one using the old approach of systematic lit reviews and regression and determining it that way. And we're going to compare how effective they are for COPD risk stratification. So predictive models are reasonably similar in their terms of predictive performance. And before you go off and make your own or spend a lot of time developing one where one already exists, how much better is it, and is it worth that time? Because remember, we have an opportunity cost. If we spend time developing this model, we haven't spent time working on something else. And so that comes in to impactability modeling, which is our third tool in our toolkit. So we've segmented our population, we've thought about risk and who's, you know, rising, who's in which risk pools. Impactability modeling is where we're going to say, where are we going to actually have an effect? Who's likely to respond to the intervention that we try to impose? So in the triangle, you've got, this is the idea of moving between risk groups. If somebody's living at low complexity urgent care, so that, I don't know, medium blue box, and they're living there for years, and then they suddenly move to a higher risk, what triggered that? Why are they suddenly at a higher risk? Has there been a change in their life? Has, I don't know, a highway, I don't know why they move risk. They move from one risk group to another, or perhaps you see a number of patients moving from a higher risk group suddenly to a lower risk group. Why did that happen? Did the GPs in that area implement a new program? Have they all signed up to some kind of stop smoking campaign that's been particularly effective? Using changing risk, we can identify problems that we might be able to solve. We can also identify case examples of stuff that's going really well. And trying to find these patients and kind of drag them back to everybody else is kind of the, who are we going to be able to pull back in, is kind of the key goal here. So there are multiple approaches. They are not exclusive of each other, and most models kind of have some sort of a blend. So you have ACSC models, which are very common, and there's debate on how useful they are. You have gap analysis, so how far away from our path are we? You know, have we missed one checkup for our diabetes, or have we missed multiple checkups and our eye exams and something else? How far away from NICE's, you know, clinical guideline pathway are we? And we can have gap score analyses, we can have weighted gap score analyses. We can also look at impactable moments. And impactable moments are, is it better to talk to somebody about quitting smoking when they come to see their GP for their vaccine? Or should we talk to them about it after they've had a heart attack or a stroke in A&E? Which location are they going to be most receptive, statistically, this type of patient, to actually being receptive to that advice? Because the GP's office is probably not the first time that they've ever heard that smoking causes cancer. However, after having a particularly scary life experience, they might be more open to trying to avoid that life experience again. So thinking about where in the medical pathway is the best place for certain groups of patients, because it might be different for different groups. And that was the point of segmenting them into different populations, figuring out what specific needs that subpopulation has, and then what you can do about it. And that brings in this idea of data in the whole population. So we know that the data is biased. We're analysts. We know that there's lots of problems with our data, right? And we spend a lot of time cleaning our data, editing it, figuring out how we can interpret it, what's missing, what are the limitations of our data. But remembering this in the context of, we're looking for inequalities. One of the key priorities in UK health data analytics is we're looking for inequalities in the system in most cases, or at least making sure that we're not disproportionately overfunding areas and driving further inequality creation by neglecting to think about those groups. So considering how accurately we've captured our population and what data is missing from it is kind of, I think, really important if you're going to be looking at inequality issues, which most population health projects are going to incorporate in at least some way. And then this is, so can algorithms travel? No, right? Algorithms can't travel. You can't pick up an algorithm that was developed in the United States, plop it down in the US, and expect it to work. For one thing, algorithms from the US tend to include region. The Southern United States doesn't have something where we can quickly tweak it to fit the UK. So thinking about the fact that algorithms are developed on specific subpopulations, these models might not be appropriate in a UK setting. However, they are useful to study and look at and maybe tweak, adapt, develop. They could be a good starting place for us to develop into something that's useful for our specific area or location. And that's one of the reasons why AphA is so cool, because we have the opportunity to network and collect and collaborate with other analysts who are working in other parts of the country, and something that they've developed, you know, on the West Coast might be great for the East Coast with a bit of tweaking. And that's why openly sharing the codes and methodologies, sharing your process for doing things, because if you can see what's inside that black box, if you can see what the code was, why they made certain decisions, what the methodological rationale was here, then you can determine whether or not that's going to apply in your setting and whether or not you need to tweak it in certain ways. And so the point that I wanted to end on was thinking about coming all the way back to that decision, all the way back to the beginning where we were talking about the priorities that we've set. So we've used all these tools, we've used segmentation, risk strat, and impactability, and we've come up with these pretty charts. We've come up with some recommendations, and that's the key, the recommendation, the analysis. What action are we going to take based on the graphs and the numbers and the report that we just made? Because like one of the frustrating things as an analyst, in the NHS is maybe feeling like your work isn't used. You spend all this time making something and then nobody looks at it, nobody takes an action on it, or they look at it and say, okay, yeah, but I'm going to go do this thing instead. Even though the data says to do that, I want to do that. So being aware that the purpose of the model was to inform decision making. PHM is supposed to create analytical outputs that allow us to make better decisions for our population. However, remember that models from that academic ivory tower are assessed based on how accurate they are, not by their ability to improve decision making. And so there's this disconnect there that we need to think about and address from the beginning and keep in mind all the way through projects in order to have them be useful. So models are often criticized because, oh, it's really super accurate, but I can't do anything about it. Or, okay, you've successfully identified these patients, but they're going to die anyway. Or they're going to just simply get better because we know that patients regress to the mean. So targeting additional resources at those patients might not have a positive effect. They could even have a negative effect. And that's money that we haven't spent somewhere else. So if you take like one thing away, like the key things to take away from my part of the talk before Hugh goes, which he'll go into more stuff, is PHM is a toolkit. However, you have to know how to use the tools and why you're using those tools. So it's not really helpful to use a hammer to try to screw in a screw. You need to be thinking about what's the purpose of each type of tool that you're using and what is the ultimate aim or the ultimate goal. I don't want a perfect model. I want something useful. And finding that balance between something that's academically robust and the decision makers can say, I'm basing my decision on this robust piece of evidence, and actually having them use the evidence and not spending years and years and years developing something and tons of money to solve a very small problem. So thinking about the size of the problem compared to the effort you're going to put into solving it. I don't know why my camera's moving around because I'm not moving. And then building that in all along the pathway while you're using the toolkit. And yeah, any questions for me?
Thank you very much, Heather. That was fascinating and an amazing amount of content. I think that must have been at least 2 master's courses squeezed into your 23 slides. There's huge amounts for us to learn. I think you've got a couple of questions in the chat, then I'll open it out. If you're, I know you've got to get to class, so if you're okay to have a couple of minutes. Question from Helen Green around how do you prevent impactability modeling from widening health inequality? So I'm interpreting that as your impactability model may say that the people who are actually most in need of your proactive intervention are the least likely to actually interact with your intervention, which is something that Hugo's data shows as well. So I don't know if you could comment on that.
Yeah, so some impactability modeling is actually designed for that purpose. So for example, in the United States, that's why I've included it but crossed it out here, excluding patients who are unlikely to respond. It's not recommended because it almost always drives inequalities. But it's used in the US, for example, by insurance companies to screen for patients that they don't want because they know that they have increased costs of their care. I think Impactability modeling is particularly good at saying you have this subgroup of a population, and yeah, they're not responding. They're not going to their diabetes education classes when they're first diagnosed. Okay, we've identified them. Why aren't they? And that's kind of the key part in our jobs as analysts, is saying, why is that happening? What are the potential reasons for that? Maybe it's because the health education classes are only happening on weekday evenings, and most people can't get childcare, or they're working, and if they take time off work, then they get less money, and then they have trouble paying their bills. There might be significant reasons why. And so then that allows us, when we're thinking about the bundle of packages that a PCN is going to purchase for its population, it allows us to include things like digital education apps that allow people the flexibility to take that education when they need it. And so, yeah, impactability modeling is going to identify and flag inequalities. But if we've designed it in such a way that we are thinking about that when we're designing it, so that we're trying to catch those, and then thinking about why that inequality is taking place, and are there potential solutions that we can implement to specifically address that and not leaving them behind. So yeah, they're not coming to the classes, but there is something we can do. We can make the classes digital.
Okay. Yeah, that makes a lot of sense. Thank you. Question from Mark, and I'll come back to Hugo's question. Mark Parker, how would you describe the difference between PHM and the health improvement work, which would traditionally have been called public health?
Yeah, so I think this comes back, so this is kind of controversial. I will start and just say that right there. Depending on who you ask, people have very strong opinions about this, and I prefer to not really have the debate. I don't personally like to argue taxonomy, but I think population health is being used specifically to address the idea of, we're going to have a set population and we're going to think about their health and well-being long term. So I think some of the key things are that we're thinking about it long term, and we're intentionally using it for the idea of resource allocation. So public health, kind of, at least my experience of it and my degree, focused more around issues like how we're going to tackle things like STIs, how we're going to think about things like epidemics like obesity, but we're going to think about them as an epidemic, as a problem to solve. But a lot of the discipline from public health has been population health isn't different, in the same way that biology and chemistry have a lot of overlap. There's a very significant amount of overlap. I think that why people are calling PHM new is because 20 years ago, we didn't have integrated data lakes that were capable of pulling GP data from electronic health records that are relatively, systematically, we've got homogeneous data entry, right? We don't have to dig through paper notes from doctors. It's more of a recognition that we now have the resources in tech and in analytics to actually do something with that information in real time for people who are on the ground making decisions about what services they're going to order for the next year for their hospitals. And so I kind of just think that it's kind of, if you want to call it a branch, if you want to call it a different discipline, I personally don't. That's very controversial, though. A lot of people think that there's a very distinct definition. They will tell you all about the distinct definition. I personally just prefer to do the analytics. Because,
cool.
Yeah.
Thank you. Yeah, really, yeah, that really answering. Yeah, and then we'll just wrap up the question, Hugo, and I think we need to move on, which is, where do we start finding some of these models? So a lot of this has already gone on elsewhere. So where do we start going in terms of finding them? And what skills do you think analysts need to have to really understand them and then adapt them for their own purposes?
Yeah. So as far as where to find them, a lot of the models, if you go into some of the PHM stuff that NHSC has produced, they have links to the different models. I think we're also going to share my slides after. So the specific models that I listed, you could go look at the stratification models. As far as developing them yourself, I think that so the models that we build at the Health Economics Unit, one person doesn't build. We have data scientists who do a lot of the machine learning. We have people like me, health economists, who do a lot of the pathway mapping, the logic modeling, thinking about like the overall structure that we're looking at. I would be very, very impressed if I found an analyst who could do every single step of the pathway and had all of like the knowledge to do it. I think it's really well done in teams. But as far as like technical skills, you can do pretty much everything for a population health project in R, or if Python, whatever you choose to use. So the software that you need it doesn't have to be complex, it doesn't have to be expensive. And some of my colleagues won't like this, but I don't think that the math is super complex. It's relatively straightforward, and it's learnable. The DSU is offering courses. NHS England is currently holding courses where they're teaching how to practically actually do like each of these segments. So you can go on courses and learn how to actually do the coding to do this on your data sets, which if you are really interested in this, I recommend doing. I think I've taught a couple of these. The next one I'm teaching starts in January. I'm teaching it with Bruno, and Bruno is doing the really super hard causal inference machine learning stuff because that is his forte. So that's again where I pass to somebody who's more of an expert in that. Bruno has a master's in data science. That is his thing. So I pull in help. It's basically my answer.
Yeah. No, it was not a complicated answer to what was a complicated question, I guess, actually. Yeah. So that's really helpful. Brilliant. Thank you. Well, let's leave it there. Heather, really, thank you very much for a fantastic presentation. Really appreciate it. And thank you for fitting us into your schedule. And we'll pass across to Hugo.
Okay, thank you very much. I'm going to share my screen. And I'm going to try to bring us back to schedule so that we all finish on time. As Alex said at the start of the meeting, I think one of the, please let me know if you can see my screen. I think one of the aspirations that we have in the branch is that we will be able to showcase a bit of the work that we're doing and share a bit of a work in progress with the rest of the region so that we can both get some feedback, let everybody know what we're doing, and also potentially open opportunities for collaboration. So we're happy to be the guinea pigs this time and to just be the first one to share. But I hope the same way that we're sharing today, this piece of work that we developed, we will see many of you coming forward to share some of the work. I have to be straightforward since the beginning. So this is work that was developed by my team. Some of them are in this meeting. So all the credit, all the good things that you will see in the presentation, all the credit goes to them. If you spot any mistakes, typos, or any errors, I take responsibility for those. Probably me misunderstanding, misreading what they did. So big thanks to the team for the effort that they have put on developing this. There you go. Next one. I just want to have a bit of a diversity and inclusion share very quickly before getting into the slides. Often when I have these presentations with wider groups, I like to do this kind of shares just to create a bit of awareness. In this case, I think it's very timely because we are going to be talking about deprivation in all areas. Maybe some of us live very close to some of these areas that are deprived. So I just want to be clear and upfront that the spirit of this is not to offend anybody and not to hurt any sensitivities, but just to share a bit of the information of what we have found. Also very upfront with the fact that because we are looking at a data set of a lot of the analysis that we did was on the data set that we have in our trust. We have a very a small number of people that tick the box indicating their ethnicity when they are not white. So looking into the detail of all individual ethnic groups, it was very difficult from a statistical point of view. So we have done probably not very good practice, but we group all of them in other ethnicity. So please again, I don't want to offend anybody or hurt any sensitivities. We are aware of, there are big differences among these ethnic groups, and that is very difficult to see them as a whole. But even, you know, you will see in the results, even with this big aggregation that we did, we already kind of start to see the differences between white population and ethnic minorities. I think having the opportunity to bring this to get this insight is more important at the moment than trying to dig into the detail and being too specific about different ethnic groups that we have. After clarifying this, I think this is probably relevant after the presentation of Heather about what health inequalities. Actually, she had a way better chart for equality and equity that I'm certainly going to take for next presentation. But I think it was important for us to understand that health inequalities. It talks about these differences in health status or the distribution of health resources between different groups. A bit of the background, and aware of time, I'm going to keep it short. This was a piece of work that we developed for our trust, for the inequalities working group in our trust, because they are very interested to understand how a SNP can be sure that all vulnerable groups have the proper access to health services. And because we're very interested in understanding how access to health is affecting health outcomes, and we'll get to that in a minute. A lot of what we are going to talk about, and I'm quite sure you are well familiar with, is we're going to talk about socioeconomic conditions, and we look at it from using the index of deprivation, or we will look at it from a deprivation perspective. You probably were very aware of this, how the index is built, and it considers 7 domains of deprivation: income, employment, education, health, crime, barriers to housing, and living environment. And all of them come together into a aggregated index of deprivation that then it was used to split all the postcodes in the country in 10 deciles or 5 quantiles. To help us to understand what regions are in the bottom 10, so in the 10% or the 20%, depending if we are using the decile quantile, most deprived parts of the country, and which ones are on the top, so the ones that are less deprived, more wealthy, with better access to employment, education, health, etc. So we produced a large analytical report that investigated socioeconomic inequalities in relation to behavioral risk factors and access to care. And what we are going to share with you today is a summary, a couple of snapshots from that report. I think we have 2 aims. The first one is to share what are we doing in the trust. If someone would like to give some feedback or share something similar that they have, it will be great. And also, I think, open opportunities for collaboration. I think a lot of these issues will touch in the work that others are doing across the region. So it will be great if we can start to use this network to collaborate and share resources and lessons learned, etc. A bit of a look at our catching area. So you probably know SNP covers both as the name say, it covers the east of Suffolk and the northeast of Essex, and we roughly split it based on our two hospitals, Ipswich and Colchester. And although we see some similarities, you will see that as we dig into detail, the two regions are quite different and have very particular differences in terms of deprivation, ethnicity, and so on. Interesting fact is that 20% of people in our catching area is over 60. So obviously we know that after you are 60, you are more prone to certain health conditions. So we have a very interesting group there. The average age is of about 41 years old. Interestingly enough, we don't have we have a larger proportion of white people or white British people in our catching area than the average in England and Wales. The average is 81%, and we have about 91. You see that majority of the people living in all areas live in the upper half of the deprivation ladder, so the deciles 6 to 10, and about 40% live in the most deprived areas. Interestingly enough, 6% of residents in our Colchester catchment area live in one of the among the most deprived areas in the country, and obviously that comes with some challenges. And you see that there is also a large proportion of people in East Suffolk that lives in the decile 2, so within the 20% most deprived areas in the country. And there are significant differences of where these areas are, and whether they're urban areas or rural areas, and the composition in terms of ethnicity. Looking, at the wider picture, and why a bit of why we're looking at this is because we know that most deprived areas have worse health outcomes. You can see here, Tendring, Ipswich are among the worst, the worst 95, so the worst areas in the country in indicators like mortality rate per 100,000 and under 75 mortality rate from causes considerable preventable. And obviously this is a big issue, and I think a waiting call for us to try to approach these areas in a different way, especially if they are preventable conditions, and be sure that people living in these areas have proper access to help. Just to finish with our overview of the SNF catching area, something interesting relating population age, demographics, and deprivation. You see that there is a disproportionate amount of non-white people that lives in the most deprived areas. So there's certainly unfortunate correlation between deprivation and ethnicity, and that will reflect in a lot of the analysis that we did. You also see that the average age seems to increase as you go from the most deprived, the quintile 1, to the less deprived quintile 5 areas. So that also changed the kind of conditions people come with to the hospital, and why, and condition-wise, we might see some more patients or more inpatients on particular areas, and we might be seeing more emergency admissions, for example, and others. Briefly looking at socioeconomic inequalities in the access to care. This is just looking at our patients, and I think it just highlights the disproportion between the most deprived areas, in this case the deprivation quintile 1, and the less deprived areas. So you see the difference between in the rate per 100,000 of population, the difference between the admissions at the in the A&E. So there's way many more people from you are way more likely if you're living in the quintile 1 area to come through the A&E than if you are in a less deprived area. This is also seen when you look at inpatient rates they're way more likely to come, and there is disproportionate amount of patients coming from these areas. Interestingly enough, you see that there is a bit of a U or a semicircle there, so it is coming back up when we start to get to the less deprived areas, and this is something that we have started to see in further analysis that we have done that is associated with age, as we saw in the previous slide. People living in the less deprived areas are slightly older, and therefore they are coming, but they're coming with different conditions and different problems, and probably for different reasons. Interesting was to look at DNAs and cancellations, a very hot topic, I think, for all of us, as well. First means that people is missing the opportunity that they have to access care, and particularly now, it is, once that you miss your appointment, you might not get one until a couple of weeks from now, a couple of months maybe. And the other reason is obviously is we waste resources that were allocated to treat the patient, especially if the patient didn't show up. Well, that resource could have been utilized to serve somebody else. You see that again, we see the same pattern, a disproportionate amount of DNAs, especially in first appointments, when you look at the most deprived areas versus the least deprived. We are starting to do some work to try to identify these patients, some of this predictive modeling that Heather was talking before, try to identify how can we spot these patients when they're still in the list of appointments, so that we can maybe remind them or helping them to rebook or reschedule their appointment rather than not show. Interestingly enough, some people in this area probably they just don't know how to do it, or simply they feel uncomfortable having to go to reschedule their appointments. We might be able to help them there. We saw the emergency attendances and people coming to the emergency and the disproportion on the quantiles. So I'm not going to dive too much into detail here because we are a bit short of time. But this slide just bring a bit more detail to that picture. You see this disproportionate amount of attendances when we look at the bottom deciles compared to the top deciles, and we are investigating. I'm going to show in a minute how this is also linked to ethnicity, because it has also a component of ethnicity, unfortunately. A moment. A very short summary of what we saw in terms of behavioral risk factors associated with poor health. We look at obesity, smoking, and also we look at COVID and how likely was people to come for the vaccine, and how disproportionately affected was people in deprived areas by COVID, especially when you look at deaths, is the mortality due to COVID is considerably higher. An interesting one is the obesity. You see child obesity rates are two times higher in the 20% most deprived areas, so the quantile 1, than it is in the least deprived areas. And we map this, and you see the dark red areas are both most deprived areas, where we have over 100% of all admissions were reporting per 100,000 population was reporting obesity as a comorbidity. So, and you see this is concentrated in around Ipswich, and and it shows areas that have these both problems, and the fact that they are they have high number of admissions with obesity, while at the same time coming from a very deprived background. Contrary, you don't see any dark blues. Dark blues will be you are from a less deprived background, but you do still have high levels of admissions, or have a high number of people coming with obesity as a comorbidity. You saw that most of the least deprived areas are in light blue. That means that they have relatively low number of admissions coming with that comorbidity, while most of the most deprived areas are either in red or in a dark orange. That shows that most of them actually have a high prevalence of obesity. Something similar and very interesting, I was talking about these differences between Suffolk and Essex, and you see that obesity in Suffolk is considerably higher than it is in Essex. And I'm just going to go back to reflect a bit on the map. And we found that this was very important to do this analysis, also looking at geography, because you see that deprived areas in Suffolk are urban areas close to, well, in Ipswich, while deprived areas in Essex are more rural areas, far away from Colchester, while Clacton and Tendring, etc. And obviously that has different behaviors. So this emphasizes the need for us to look at catching areas in two different ways. I'm going to probably just go quickly to the couple of slides that I have left, so we still have some time for wrapping up. Child obesity, similar outcomes. Deprivation seems to be a high factor when determining whether we're going to see children coming to the hospital that report obesity as a comorbidity. Conclusions that we make out of this first phase of our work was that the health inequalities is an issue in our catchment area, and I think we show a couple of examples that show that people from most deprived communities disproportionately use our services. So going back to the issues that Heather was pointing out in her presentation, so how much resources are we spending on probably on conditions that could be preventable, or circumstances that could be preventable if people will have proper access to our services, or if we will facilitate somehow, or we will do an extra effort to make the services closer to them. Patients from most deprived communities are more likely to miss planned appointments, so no showing ups. The acuity of conditions of patients from most deprived communities might be worse. And I'm not going to expand on the limitations of analysis, but when you get this slide pack, please read them so that you take some of the results with a pinch of salt. The work that we're doing now, and probably the most interesting part of this, is that this is the work that came out as a result of this initial phase. We've worked a lot, as you saw, in regarding health inequalities and access to care, and now we are digging into outcomes inequalities, looking at different comorbidities, risk factors, and how what we are seeing in the access to healthcare is affecting patients' condition. Something that we just because I think this one is interesting to share on the work that we're doing at the moment, because I mentioned before, we are trying to untangle a bit this correlation between the different variables. So we are aware that there is a link between ethnicity and deprivation, and we are trying to show or to evidence that there are both components affecting, and both should be taken into consideration. So we did this modification of a decision tree where you can see that, well, people from in most deprived areas, there is 1.78% people from other ethnicities. So that's what you would expect coming through your emergency department if ethnicity will not be a factor. However, we see 6.5% out of the people that come from the most deprived areas have other ethnicity. And you don't see this difference, this strong difference when you look at the less deprived side. So it's really affecting the most deprived areas. Just to close, so I leave Alex at least 5 minutes to do the wrap up. So a lot of the work that we'll be doing now is going to be focused on the core plus 5. You probably are familiar with that. So focusing on the most deprived areas plus any vulnerable group, and taking the 5 key clinical areas of health inequalities: cancer, hypertension, chronic respiratory disease, annual health checks, and maternity care plans. we'll be very, as I said, it's now, we will be happy to hear from any of you that is doing something related and would like to share, would like to discuss the work that we're doing, or would like to cooperate with us and work together. We'll be very happy to hear from you. So probably we don't have time for questions, but certainly you have my email, or you can write to Alex, and we'll be happy to get in touch and have a chat with you. So I'll give it back to you, Alex. You at least have 5 minutes for the wrap up.
Yeah, thanks, Hugo. That was really good. Lots of content in there. And sorry, we're running out of time. But yeah, as Hugo says, if anyone's got any questions, we'll share this with everyone. Hopefully it's of interest. Keen to get feedback. And by all means, feel free to get in contact with us. Right, Robin, do you want to ask one quick question?
No, actually, that was my mouse not doing what my mouse should have been done. It got stuck, so I've got a lingering hand that I can't get rid of.
Right, we'll try and ignore that one. That one. Right, okay. In terms of next steps, just to wrap up in the next, just only take 2 minutes. You thought Menti was finished? Not quite. So, in the spirit of live radical candor, did you find today's event useful? No or indifferent? Fantastic. Lots of yeses. I'll take that as lots of positives. I think that's pretty good going. So I'm glad. Yeah, everyone found it useful, and that's really excellent. Thank you. So yeah, just kind of pitch for another couple of other events that in the region. The East of England PHM Analytical Skills Development Network is next Wednesday, focusing on risk stratification. So Helen Green and David Martin, who are in, or certainly were in the call earlier, leading on that, and obviously a similar theme. And the AphA annual conference is taking place in May next year, so that is now open for registration. Will be coffee and croissants. Okay, so just to wrap up, then I've got a couple of asks of everyone really, which is I think first of all is just, can everyone try and take an action away, which is just advertise this network to one other person who you think would benefit from it. I think that would be a helpful thing to do, because I'm very conscious that we also had some really good coverage today. We don't yet, there are some significant organizations without any representation yet, and it would be helpful to expand out where possible. And if you would like to volunteer a presentation for a future event, we don't really have a theme as such for the next event. That doesn't matter, I think, at this stage. If you would like to come forward and present something, whatever that may be, by all means, do feel free to contact myself. My email address is there for you. If you have any AphA related queries about membership, registration, etc., I suggest you go to Val, who is the AphA business manager, and on the call. So on